Continual tooth movement is something that you speak about a lot. You've even got your own famous hand gesture. Just talk to me about, in just a quick sort of 5 to 6 minutes, the concept of continual tooth movement most dentists don't know about, the impact it can have on their patients and the treatments that they perform.
It's a massive impact. I kind of sort of tripped up on it all quite a few years ago, and you'd think that continual tooth movement is something every dentist understands, and I think every dentist kind of knows that that might be going on. I think why it never really impacted on the profession the way it should have is because most dentists don't simply take long-term photographs of their patients, and a lot of the people that teach us and taught us don't have 10-15 year follow-ups of patients, and so we didn't really appreciate it. It was only just by taking these photographs and seeing these actual movements and doing a lot of orthodontic kind of reading that I came across a little study. When I read it for the first time, you know, it was kind of jaw-dropping, and I had to kind of double take and read it a couple of times, because effectively it was telling me that the teeth that I had been, you know, veneering or putting fillings on or crowning were ultimately all moving, and I knew, as someone that kind of understands a little bit about occlusion, what impact that can have on those teeth. I spoke to some orthodontists about it who I knew and said, "Oh, did you know about this?" And they said, "Yeah, of course, the teeth kind of do continue to move." I think what they didn't quite get was what effect that has on the occlusion. And actually, that's been clearly stated, because, you know, in 2008, it's a bit of a controversial comment this, but in 2008, the Department of Health and the Orthodontic Society, they released a statement to orthodontists telling them that all cases need to be retained for 1 year. And that created a bit of a shock and drama, but I mean, that's a good thing. But in the letter to them, it also said that, but for 1 year only, because all orthodontic relapse is of a cosmetic nature only. That's the problem I've got. I think that statement has been made by people who haven't observed their own patients over 15, 20 years, because actually what I realised was continued tooth movement causes very commonly a constricting envelope of function. And as we commonly do, and we're describing to patients about how their teeth should be, and I'm always moving my hands to this position, we make a bit of a joke about it in courses, but every day I'm talking to patients about an envelope of function and saying, you know, your teeth, if they were in the right position with the right overjet and overbite, would be like this, and then when you're chewing, you'll be chewing through your food and then you'll be returning to that position. But in your case, Mrs. Smith, your lower central is drifting forward and it's knocking your upper tooth. So every time you're chewing, you're getting a very slight rubbing effect, and that's what's causing that lower tooth to wear away. That's what's causing your upper tooth to potentially even move and move forward. And so as a restorative dentist, seeing that, understanding it, seeing it on my own patients was just in my career, the greatest revelations I've ever had, that impacted my dentistry so dramatically. And I know when I bring this to dentists on these courses, it's the biggest eye-opening moment they have, and I can see many of them suddenly panic about the case they fitted a couple of weeks ago, and they didn't even look at the lower tooth and the occlusion and see how that's likely to change. So continued tooth movement is massive. The problem with it is it probably was in an orthodontic article, but it actually has enormous restorative consequences globally. And whenever I travel around the world and I'm lecturing, I will show cases where a typical problem occurs. The patient, we all know the patient with the repeatedly chipping front tooth, okay? We've all had them. Every dentist would have treated many patients like this. And I show a couple of different examples that we commonly see. And I say to dentists, this patient's front tooth keeps chipping, anterior crowding. What do you think most dentists would do with this patient after the tooth has chipped 5, 6, 7, 8, 9 times? Everywhere I travel, there could be 5 people in the audience, there could be 1,000. Everywhere I travel, everyone says that tooth would have a venereal crown. And this is the thing, everybody's wrong. You know, I was wrong. And the reason why we all believed that was because we were kept away from orthodontics, because somehow it was something we shouldn't have been doing. But actually that attitude has damaged patients. It's damaged people all around the world. It's damaging them now because general dentists are told you're not allowed to do ortho. And orthodontists, understandably, wouldn't see the consequences of a constricting envelope because they're not seeing the patients continually. They don't look at patients who they haven't treated. A general dentist will see patients who haven't been treated and will see the functional consequences. So actually, the profession has a lot to answer for, because for our convenience, we haven't been told it, it's been kept away from it, but the reality is we need to know, and every general dentist needs to understand what can happen with changing anterior occlusion. So you can see it's a really important subject, and it's also why this teaching, I encapsulate it and describe it not as orthodontics, it's ortho-restorative dentistry. The restorative part is just as important as the orthodontics, and in my opinion, in many adults, orthodontics on its own, without some restorative thinking, whether it's planning of position, function, restoring guidance, it's not good enough. Orthodontics on its own is not good enough. Restorative dentistry on its own, in a crowded situation, is not good enough. Together, they give us the ideal situation.